and yeah, others can find us, yeah, on our way. So please welcome to everyone to our solid webinar titled Driving Improvement, Good Practice and Innovation in South Africa's District Health System. My name is Noluthando Ndlovu, and I'm from the Health Systems Trust, and I work in the research team. I will be your facilitator for today with some really awesome speakers lined up. So, just to give some context in terms of what we're discussing today, across South Africa, people are working in districts and in primary healthcare, and they're constantly finding ways in which to innovate. They find creative solutions, sometimes bold, sometimes solutions to challenges like limited resources, which is something that we're all very much aware of in the South African context. But there are also workforce pressures that we also know about and community health needs. But as we know, these successes that people are actually, coming up with on a daily basis often remain quite locked within specific facilities or in specific districts. They aren't documented, they are not shared, and sometimes not scaled. And really, if we think about it, it is quite a real loss for our system in South Africa. So this session is really about trying to change that. It's about learning from real world examples of good practices, as you'll see as we go through our session today, but also about celebrating people who are innovators and making changes with the limited resources that they're working with. It's also about strengthening the culture of improvement in the district health system, which is critically important, even more so now with our limited resources. So today is not really only just about to share stories, but we are really hoping that we inspire further collaboration and exchanges between people, between facilities, and between districts. We would really like to encourage you to use the chat to share your comments, ask questions, and even share your experiences. The Salad webinars usually have a very lively chat. So please do go there and engage and share as we speak. We will be monitoring the chat throughout the webinar, so we will be picking up on those discussions and insights as well. Please note that the webinar is recorded and the recording will be shared after at a later stage. So to introduce our first input, also just to share overall, our great speakers for today, we've got Dr. Mashudu Mthetwa, who is a researcher at the Health Systems Trust. She holds a PhD in medical physiology from Stellenbosch University and an MPH in epidemiology and biostatistics from UCT. Her work focuses on using research evidence to inform policies, but also to strengthen health systems in South Africa. Mashudu's input will be followed by Malcolm Jaager, who is a dedicated public health official holding a master's degree in environmental health and various other certifications in management. Malcolm currently works in the Free State Department of Health, where he manages the environmental health program for the Garib District Health Services. We'll then hear from Dr. Dillon Manuel, who is the dentist that manages oral health from NICE for NISNA in Bitur sub-districts. I hope I say that correctly. And his expertise lies in strategic oral health coordination, policy leadership, and delivering cost-effective clinical care in underserved communities. And our last speaker, last but not least, is Dr. Almero Oosthuizen, and he's the clinical lead for innovation and improvement at the Directorate of Clinical Service Improvement in the Western Cape Department of Health and Wellness. I could go on and on sharing about the wonderful work that these people are doing, but we really want to concentrate on the awesome inputs that they'll be sharing this afternoon. So starting off with Mashudu, I would like to introduce her as our first speaker, and she will take us through what is a good practice in the district health system, and she'll share a little bit about the work that's been done to establish a good practice repository. So over to you, Mashudu. Mashudu, you're muted. Yeah, thanks.
Thank you, Nolu. I'm not able to open my slides. Could you please share on my behalf?
Sure. Sipo, do you have them? Oh, there we go. Thank you, Carissa.
Thank you. Good day, everyone. As Nolu has shared, today I will share what constitutes a good practice in the district health system. Next slide. Across many health systems, some of the most impactful innovations are born not from large budgets, but out of lack of resources and the necessity to meet healthcare needs of the populations. Today, I would like to connect this concept of Jugaad innovation with the idea of good practices. So Jugaad is a Hindi word that describes improvised solutions to complex health problems using scarce resources. So frugal, flexible, and creative problem solving. Next slide. One of the major examples of a frugal innovation includes an Embrace infant warmer, which was first implemented in India. It is a low-cost portable device designed to keep premature babies warm in resource-constrained settings where incubators may not be available or electricity is unreliable. It uses a simple phase change technology, requires no continuous power, and has saved a lot of newborns globally. So this Embrace technology shows that life-saving innovation can be simple, affordable, and tailored to real-world constraints. Next slide. So what is a good practice in the district health system? Across South Africa, as we are all aware, districts face challenges such as staff shortages, limited budgets, high patient loads, weak infrastructure, and data quality changes. Yet they still find creative low-cost solutions that improve service delivery, capturing the essence of Jugaad, which is to do more with less. So a good practice may be described as a solution, often frugal, that improves health outcomes or system performance. It should be supported by data or evidence of improvement. It should be feasible using routine district resources. It should be sustainable beyond donor funding and adaptable across districts. Next slide. So some of simple yet impactful innovations within the district health system include facility flow redesign with color-coded systems, which is a way to decongest facilities and reduce waiting times using simple colored folders, arrows, or station markers. Use of WhatsApp for patient tracing, tracking missed appointment, and follow-up on TB contacts, or sharing rapid updates. As well as low-cost outreach models, such as the Do-Art model, which is a differentiated ART model that extends HIV treatment and other health services into the communities or where people work. Next slide. However, most innovations and good practices within the district health systems remain undocumented. This results in valuable lessons, successes, and challenges being lost or inaccessible. So why is it important to document good practices? It enables learning across districts and programs, supports evidence-informed decision-making. It helps identify what works without reinventing the wheel or duplication of efforts. It facilitates replication and scale-up of effective practices and enhances accountability. However, several barriers to documentation exist. This includes limited capacity. As we've said, most of these facilities are often short-staffed, leading to limited capacity to do anything else. Skills or training in writing, monitoring, and reporting also is a barrier to documentation. Absence of standardized templates or processes for documentation, siloed operations across provinces and districts with very little collaboration, lack of incentives to capture innovations, and lack of dissemination pathways. Next slide. So this is a template for documenting of good practices that was adopted from the WHO. So you'd first start by identifying or describing the problem that is being addressed, then describe the intervention or the proposed solution to this problem, then describe the methods or steps taken to address the problem, then list key outcomes and successes. This should include quantitative measures or perceived benefit or qualitative evidence for perceived benefits. Additionally, describe challenges and lessons learned, which can inform replication in other contexts. Next slide. So this is a WHO good practices criteria. This is how a good practice would be validated. So according to the WHO, a good practice should reflect at least 4 of the required criteria, which are on the green side, and at least any other one of the important criteria, which are on the purple or lavender side. So the required criteria would be effectiveness, efficiency, relevance, and ethical soundness. Additionally, you may include one of the criteria on the purple side. However, if you are inventing or if you are looking at an innovation or an intervention and you would like to use the good practice criteria to make sure that you meet what a good practice is, it is important to look at all 9 criteria. Next slide. So I'm going to give you a brief overview of the project that was conducted by HST, titled Exploring Good Practices in South Africa's Public Health Sector. I'm not going to share the results as the report has not been made publicly available. So the aim and objectives of this project was to identify, document, and share good practices within South Africa's public health, and to develop an online repository of good practices. So methods to identify good practices included a national call of submissions via online channels, provincial stakeholder engagement meetings, and review of district performance using the DHIS. The captured practices or practices that were submitted were reviewed individually by 2 members of the team and assessed against the WHO criteria for validation. We then classified the practices that were accepted into various health themes. The next steps is video documentation, where we've selected 5 most impactful practices and will document them as video showcases. Also, selected practices were presented in the report that will be submitted to NDOH. The rest of the accepted practices will be included into the good practices repository. Next slide. So what is a good practice repository? It's an initiative by HST, which will launch early next year. It will be an online platform that collects, review, and document good practices in South Africa's public health. So why do we need this good practice repository? As we've said, or as I've shared, innovations often remain undocumented, and most DHS improvements often sit in people's heads or reports or isolated pilot sites. So this good practice repository will be an open access database that will capture validated good practice from all provinces and districts, focusing on practical and working solutions that have shown measurable improvement in service delivery and health outcomes. So how it will work, we're still working on some details, but it will function as a journal where you can submit an article, like a journal for article submission. So we will have a submission portal where we will issue a call for submissions either annually or biannually. Then these practices will be reviewed and validated against the WHO criteria. Then they will be thematically classified and then documented online via this repository. So we hope that this good practice repository will promote continuous learning and improvement, will strengthen accountability through measurable results, will enhance program improvement, and build a culture of innovation and collaboration in the district health system. Next slide. Thank you so much.
Thank you so much, Mashudu, for just helping us understand the foundations and for reminding us why documenting good practices is not just an academic exercise, but also a system strengthening one. So thank you very much. We now move into a practical example, which looks into tackling antimicrobial resistance in the district health system, which is one of our strongest emerging threats. So please join me in welcoming Malcolm Jaager, who is an environmental health practitioner from Garib district in the Free State. And he's going to be sharing how his team has been addressing AMR in real world district contexts. Over to you, Malcolm.
Hi, good afternoon, and thank you so much for giving me this opportunity to present my good practice. So my title of my presentation is the One Health Approach using primary healthcare reengineering as a vehicle toward the implementation of the National Antimicrobial Resistance Strategy, Garib District Health Services. So a quick overview of where my district is. So Garib district is in the southern part of the Free State. We are home to one of the biggest reserve dams in the country, known as the Garib Dam. We have a population very small, about 134,880 people. The district health system is comprised of 4 district hospitals, 16 clinics, 1 community health center, and primarily this program is rolled out by ward-based primary healthcare outreach teams in 22 wards in our district. In 2024-25 financial year, we serviced approximately 317,000 patients in our primary healthcare clinics. We roll out the program using 8 EHPs who are environmental health practitioners over 16 clinics and the community health center. We also have 2 EHPs in on 2 of our 4 district hospitals, 7 pharmacists, 22 pharmacy assistants, as well as 198 community health workers form part of this particular project that we have rolled out in our district. Now, what is antimicrobial resistance? It says AMRs occurs when bacteria, viruses, fungi, and parasites no longer respond to antimicrobial medicines. And as a result of drug resistance, antibiotics and antimicrobial medicines become ineffective and infections become more difficult or impossible to treat, which increases the risk of disease spread, severe illness, disability, and death. Now, I'll go straight into the National Antimicrobial Resistance Strategy that was developed by NDOH in 2017, which has a main objective being to promote an understanding and a cooperation on AMRs as a one health issue across human, animal, agricultural, veterinary, and environmental health sectors. Now, what we did as a district is we sat down and we came up with 5 objectives which align with the national AMR strategy. The first one was to see how to reduce inappropriate antibiotic prescriptions by 20% from a baseline within 12 months as measured by a quarterly audit of patient files, which is audited by our pharmacy teams, where these findings are then endorsed by the AMR Stewardship Committee. The second objective was to increase community knowledge on AMRs and the rights of patients to return unused expired medication by using community health workers to educate at least by minimum 20,000 residents across our 22 wards in the district, and by ensuring that we establish 17 permanent medication drop-off box locations in each of our clinics by the end of June of 2024. The third objective was for how we are going to increase compliance in our clinics to make sure that the healthcare waste management system in our clinics comply with requirements of the OHSC from 85% to 100% of all our facilities within our district over 12 months. And this will be verified through monthly inspections that is done by environmental health practitioners. The fourth objective was to see how we can take hands with our pharmacy team to develop a system where we will demonstrate how the district will save in excess of 1.5 million rand from prevented waste. This will be achieved by ensuring that less than 1% of total pharmaceutical inventory expires on shelves, down from the current baseline of 5% as verified by end-of-year stock take protocols. Then the last one, it says by the end of the current financial year, we must implement a formal accountability policy where any healthcare facility which exceeds its annual pharmaceutical waste target by 15% must, number one, submit a root cause analysis report to management. And secondly, they are required to implement a mandatory waste reduction plan. The success of this policy will be measured by 100% submission rate of required reports from uncompliant facilities. Now, this is what we do every day. So what we did as environmental health is, number one, we trained all our community health workers on antimicrobial resistance and what it does. We also then gave them the tools of trade for them to educate patients in communities on AMRs. We also encourage CHWs while they do home visits to also then check, rather like inspect the medication that patients are prescribed to make sure they finish the full course of antibiotics prescribed to them. Also, we then request the CHWs to return any unused or expired medication from households back to the nearest healthcare facility where they are linked. Now, facility management, basically, we have established 17 drop-off boxes where patients who want to return unused expired medication are allowed to do that with the greatest of ease to any of the nearest healthcare facilities. So at a pharmacy or in a waiting area, there'll be these dark green pharmaceutical waste boxes that have been placed out strategically for them to return medication without judgment and without being scolded. On a monthly basis, EHPs go out, they make sure that the waste management system works, including the pharmaceutical waste collection and management program. We look at data management. We also report the data in our antimicrobial stewardship committee meetings. We also sit and discuss the kind of work that CHWs do in our communities. We then also look at how do we support community health workers where there are challenges with regard to the implementation of the program. And then once annually, we sit down as a team with myself from environmental health, as well as our pharmaceutical management team, where we now centralize the collection of all our pharmaceuticals that was generated in our district. Now, this is basically the pharmaceuticals that was generated within the facility, and that which was brought back by patients to our healthcare facility, so we can be able to separate how much was generated by the facility and that which was returned as patient returns. And the last thing we did is we developed a WhatsApp group. Now, the WhatsApp group is referred to as the redistribution group. Now, in the redistribution group, we remember some of the services that we render as part of our district health services is outreach services. So now you have your social workers, you have your environmental health practitioners, you have your physiotherapists, your OTs who outreach to various healthcare facilities across the district. And in the WhatsApp group, a pharmacist or a pharmacy assistant will indicate that they've got a package that needs to be moved from facility X to facility Z, and then the documentation will accompany the person. And in this way, we try to make sure that a facility that is short of medication or that which has excess medication is able to move that within the district just to try and make sure that we prevent the wastage of pharmaceuticals rather, sorry. So the results to date, so I'm going to go straight into the results so firstly, our pharmacy team did 169 clinical audits, of which only 63% were found to be compliant. Now, what happens here is the pharmacist would then give a report to the facility manager, who must come up with a quality improvement plan to kind of correct the incorrect prescriptions done by clinicians within healthcare facilities. The second achievement here is we were able to educate 24,312 patients on AMRs and their rights to return unused expired medication within the 23-24 financial year. So we were also able to return pharmaceuticals from 130 households across our district. Now, the OHSC also found that our healthcare waste management system to be compliant, and 100% of our pharmaceutical waste management services received an excellent grading from the Office of Health and its Compliance. Then the WhatsApp group. So this is the result from what we have done through the WhatsApp group. So routinely, like I said, we would redistribute medication across the district. So these are the numbers I got from our pharmacy manager. For the 24-25 financial year, including the current financial year, we were able to save the district in excess of 4.5 million rand in prevented waste. So our patient returns account for 354.19 kilograms of all pharmaceutical waste we had generated in the 23-24 financial year. The cost to treat the waste was about 7,682.32, which is only 12% of our total expenditure for pharmaceutical waste treatment. Now, the cost of the program and the environment can at this stage not be determined, but there is a reassurance that 354.19 kilograms of pharmaceutical waste or expired or unused medicine was not dumped on a landfill site, was not illegally dumped or flushed down a toilet, which potentially will pollute rivers, dams, and streams. Now, the last finding here is research finds that if pharmaceutical waste at these volumes were to have been flushed down a toilet, it may disrupt the effective operation of a conventional wastewater treatment plant that utilizes bacteria to break down waste. These antibiotics and other drugs may disrupt these essential microbial ecosystems, reducing the plant's efficiency. We also have challenges. We have learned lessons, and there are many successes. The first of which is the district is vast, including the wards, sometimes discouraging walking long distances to educate and collect expired or unused pharmaceuticals. We also a district that has adverse weather conditions, so it gets really hot and gets really cold in winter. Now, the lessons that we have learned here is that ward-based primary healthcare outreach teams are good drivers of the One Health approach to prevent the incorrect disposal of unused expired medication. The environmental health program will keep monitoring and encouraging the return of unused expired medication while encouraging patients to finish the full course of antibiotics prescribed to them by healthcare professionals. Lastly, we said our antimicrobial stewardship meetings and our clinical governance meetings are regular, and great attention is paid to non-compliance and the implementation of quality improvement plans. Now, these are just a few of our pictures. You can see a community health worker doing a household visit where they would actually check the medication from the patients. In the box there, you see that's expired medication that came back from households. Then the dark green containers there are examples of what I'd spoken about, where we place these out in various strategic points in our clinics just to make sure that patients can return unused medication. You can see on the far right here, the center right here, you can see how full the pharmaceutical waste bins are. And then once a quarter rather, we go out with our ward-based primary healthcare outreach teams just to actually physically see how they do the work that we did a presentation on today and a good practice. And yeah, so with that said, this is just a few of our pictures of our HST video that we hope to see very soon. And with that said, teamwork makes the dream work. So it says the great team of EHPs, pharmaceutical services, our CHWs are the drivers of the success of this program across the district. And without them and their support and their willingness to implement programs and strategies, none of this would be possible. So a big thank you to each of them. And with that said, thank you.
Thank you so much, Malcolm. That was really insightful and also deeply relevant. I particularly like that we focused on environmental health services, which is something that doesn't easily come to people's minds when they think of our district health system. You'll also see some comments reflecting that in the chats that this is actually a very important and crucial area in the DHS. So thank you for the inputs and for the work that you are doing with your team in Kharib, and we can't wait for people to see your video. So before we go to our next presentation, we'd really just like to hear from you as our participants, just having some engagements with you. So you can raise your hand, unmute, and then we can have a discussion. We're really interested in understanding and hearing from you. How do you see good practice in the DHS? And what examples or experiences would you like to share from either your facility, your district, or the program that you are working in? So we'd really like to just get those insights. You were also asked this message. when you registered for the webinar, and we got a lot of responses areas. So, Bulela, can I invite you and Uta to maybe comment a little bit more about what you were discussing? Can they unmute themselves, or do we
I
need to
think
help with that?
I think you can start. I think you can
Bulelo,
start
Oh,
with
go
the
great.
ahead.
person who started the conversation. I just want to say, Noluthando, that you can start with the person who started the conversation. I was just commenting.
Oh, okay. Um, Uta, if you would like to hear some of your insights, if you keen to share.
Sure. I mean that it was just a comment on it. I shared Beth's joy that there is a focus on environmental health services, which I think are often very, very undervalued in the district health system. There are municipal health services, of course, which is, I mean, they have a crucial role there. And I think they play a key role in many aspects of often sort of the non-personal aspect of health services, linked to, and they play a very multi-sectoral role because they have to interact with water and sanitation, they have to interact with solid waste, they have to interact with ECDs and so on. So they play a crucial boundary spanning role. Their role here in AMR is of course was new to me, really, really interesting to hear. But yeah, very good to see that work highlighted, and probably would be good if we got more of that. So it's really valuable. Thank you.
Thank you, Uta. We value your insights. Yeah, from just sharing a bit of the responses that we got when people were registering for the webinar, there was a lot around digital health innovations. For example, looking at electronic records and systems, but also data utilization and monitoring. We'd really like to hear a little bit more about what are people. I'm sure you have good practices. You've now heard what a good practice is and how to identify one. And Malcolm has given quite a nice example. Um, yeah, so we're really keen to hear what are people doing in their districts, anything that you feel like could be valuable to share with other people that could be done. I see somebody's got their hand up. Please, can you go ahead and unmute yourself? I can't see hands. Oh, Lucy, yes, please go ahead.
Thank you. I thought I'd just chip in something whilst others are putting their hands up, and now they're putting their hands up. That's great. It's actually just a reflection back, Mashudu, on the HST initiative, which is fantastic, and I think we all welcome it. I wondered to what extent the repository would also embrace examples that are not necessarily about service delivery, but about different ways of doing things. And that's what Malcolm's example is partly telling us. It's, of course, about AMR, but it's also about the role of EHPs, the links to CHWs, the links to the pharmacist. There's lots of good practices underlying the good practice. And I wonder whether the repository will allow space for those sorts of practices. Thanks, Nolu.
Thank you, Lucy. I'll just get, no, Mashudu, please note the question. Then I'd like to go to Dr. Valabji and then Bulela, and then we can get some responses from everyone.
Thanks very much, Nolu, and thanks to the speakers. Really fantastic presentations, and well done to HST on the repository. Just a provocative question, in a sense that the repository is an excellent initiative and almost a first step in a process, because gathering and documenting all the good practices, I think is vitally important. The question then is, how do we get that to be actually shared and actually scaled and actually spread across the country? And what would be the steps in that regard? I'm not suggesting that it's all HST's responsibility, but I'm putting the question out there about, the repository is almost a passive place to gather all the good practices, but we need active steps to get it spread. And we, as a country, I think we're not very good at sharing good practices and sharing lessons, etc. So I think there's a whole area of work to think about, and I'm just putting that out as a question. Thanks very much.
Thank you so much, Dr. Walabji. And Bulela, I think that's the last hand that I see up.
Noluthando, I can't raise my hand, but I would
Oh,
want to comment.
okay. Can you please comment after Bulela? Bulela, please go ahead.
Thank you, Nolo, for the opportunity. It's actually quite unfortunate that the person who was supposed to have made a submission, actually, when you made the call the first time, was unable to submit, despite me pushing them, of course, to share this. And it's actually a story coming out of the Eastern Cape, a brilliant innovation. Yet again, another example of how you could save the state millions or hundreds of thousands of rands in cost. And it was actually the innovative use of the PVT, patient vehicle transport system, as to serve actually as a courier service between facilities. And this actually became particularly important and it has been actually at the heart of a very successful intervention to provide rural populations in the Eastern Cape with dentures, for those with dentures, and a more colloquial term for that being false teeth. And there's a small team of dental technicians working out of a central hospital in Noluthando district. And what they did is, because when you want to provide access, of course, to these items, there's a lot of appointments, number one, that people need to attend who want to get these dentures. Two, there's a cost that must be incurred to actually between the lab and the actual practitioner on site, whether it's at a rural district hospital or a rural CHC. So innovatively enough, what was identified was that the central hospital is a hub for many of the referrals that come from these district hospitals and district hospitals around the Eastern Cape. So what happened was, in order to be able to facilitate basically the processes and make it much shorter, they actually are using, let me not say used, they actually are using the PVT transports as basically a courier service that carries basically mouth models that have been prepared already on site and are just ready for the dental technician team at the central hospital to start fabricating these dentures. And basically this system has worked so well that I think at last count when I saw the statistics, the Eastern Cape is probably second, if not third, in terms of providing these services nationally. Probably I would even argue that maybe the most latest data would probably position them as number one. But thank you very much for that.
No, thank you, Bulela, for sharing those insights around dental care. And again, very nice to hear an issue around oral care, which is often also not spoken about, similar to the environmental health services, particularly in a province where resources are limited and people are making things work, as we shared, that is quite important for the DHS. So I'll take Mr. Mdebele's comment, and then I'd like to invite then Mashudu to respond to the two questions about the repository.
Thank you, Noluthando. I'll comment on the two presentations. The first one, it's an excellent idea of creating a repository, especially from the learnings in the district, in the country. I was just sharing this week with one of the colleagues to say, how did I learn a district health system? The publications that were done by HST. So they were not doing that, but they were saying, they were documenting all of it that were done in the ISDR. So cool. up those publication in terms of transport management. So I would really encourage that on so that the other colleagues can be able to learn and we can also be able to learn. And then the second presentation from Malcolm is actually teaching all of us and is the best example of multidisciplinary teams working in teams to achieve an objective, of which as health workers, we really struggle in that field. We are used to work in silos. And the approach that the district has taken is an excellent lesson that we can all learn on. Maybe just to actually as part of expanding the pool of people that are working, that are assisting in this initiative. I'm also suggesting that also look at your DDM, because I can guarantee there are other departments who also have got field workers who can assist in this initiative. So maybe you actually need to explore that one. Thank you.
Thank you so much, Mr. Mdebele, for that feedback on the knowledge generation and sharing that HST was known for and has become known for. We appreciate these insights, and also particularly for highlighting the importance of multi-sectoral collaboration, which is something that comes up quite a lot. And when we're trying to really speak about how do we move the needle in terms of health outcomes in the country. Before I take Khaile's hand, I'd like to hear Mashudu's response, and then I have a question for Malcolm, which is in the chat. So Malcolm, could you please just check in the chat the question from Helen? And then I'll take the hand that's up. Mashudu, are you still there?
Hi, Nolu. I'm still here. I'll start with the first question about what type of practices we'll be hosting in the repository. We will host various good practices that are related to health system strengthening. This could be governance, it could be data management, it could be digital health. It won't only be targeted for service delivery outcomes, but overall health systems strengthening and public health outcomes. And for the second question, we will launch the good practices repository. And we hope that through the launch, we will also attract an audience that will be informed about the repository going forward. We'll also leverage our social media channels to actively share the existence of the repository online. And we will also do targeted email campaigns to the relevant stakeholders to just continually share about the repository. And we hope that the annual and biannual call for submissions will also play a role in increasing awareness of this platform for individuals to share good practices. Thank you.
Thanks, Mashudu. And something I think that, yeah, unfairly as the host, I can mention because I know about this project is that we also did stakeholder engagements across the 9 provinces. We went to 7 actually of the 9 provinces where we did capacity building in terms of sensitizing and sharing awareness around what is it good practice and having then people submit. So the process wasn't passive. And we do hope to continue with that going forward. So a question for you, Malcolm. What factors enabled you to start, form a team, but also to mobilize multiple stakeholders? Could you share a little bit about that before I take Khaile's comment or question?
Okay, what support do I get? I think Harib, the one thing I love most about my district is the fact that we get great support from our district management team. We also have teamwork. So whenever someone comes up with a challenge, we always find simple solutions to our problems. We always try and see what we have available to ourselves in that moment, and we try and make it work with what we have. It's not always about having money, it's about just thinking about simple solutions to complex problems. Like CHWs, I don't think many people actually, if you actually go through the National Antimicrobial Resistance Strategy, it talks about communication. And I mean, if you go through that, already it tells you who will communicate and who will do what kind of work. And then that is what we use to leverage the kind of resources and the kind of support we needed to implement such good practices in our district. Yeah, and like I said, there's good buy-in from management and from the entire team who have a problem, and then we find common solutions with using simple resources that's available to us within the district. Yeah.
Thank you so much, Malcolm. Yeah, teamwork makes the dream work.
Yeah, thanks for teamwork.
Khaile, just to close off this session, we need to move on to our next speaker. Please, can you unmute yourself and share your comments? Yeah, thank you.
Thank you, and thank you, for all the, presentations from the presenters. These are really quite exciting, information that we are getting. And I wanted to just comment on Dr. Mthetwa's presentation. I think frugal innovation is really a, good cost containment strategy to cope with resource constraints. We've seen from literature in India that they have been particularly good at, institutionalizing frugal innovation, what they call a Jaager, to cope with the resource scarcity that they are faced with. And I really think, it can be a good opportunity for South Africa to learn from some of these international best practices, especially in preparation for the NHI. There's been a lot of concerns about whether or not it will be, financially sustainable. And I think frugal innovation is one of the practices that, if institutionalized, can really help somehow, because at times it's not always about, the frills, the bells and whistles. There are other simpler strategies to still ensure that there is equity in care. I'm also busy with some, studies around the same concept, and a repository is really a very welcome development from the HST. Thank you.
Thank you. Thank you so much, Khaile. Frugal innovation. That sounds very interesting. We'd be keen to hear more about that. Thank you so much for the engagement. I'd like us to just move on to our third speaker, and this time coming from the Western Cape, where innovation in primary oral health services has brought about tangible improvements. Please can we welcome Dr. Dillon Manuel, dentist from Knysna Bitur Sub-District, who's an ICON Western Cape finalist and CPSI Innovation finalist. We told you guys we've got winners in this panel. He'll share a compelling story about improving dental services in the district health system. Over to you, Dillon.
Thank you, Nolu. I'm just a finalist. Didn't win anything yet, but hold it down. All right, let me just share my screen. All right, can everyone see my screen?
No, Dillon, we can't.
Not yet.
See?
Yes, now it's about to come on. Yeah, it's coming.
Okay, perfect. All right.
I'm just putting presentation mode.
Perfect. Are you seeing
Yes,
it?
thank you.
Okay,
Yes, perfect.
All right. Thank you, colleagues, for allowing me this time to just speak to you in the next 10 to 15 minutes about how we've transformed the oral health services in the Knysna Bitur sub-district. So, yeah, coming from the Eastern Cape, where we had a pretty large all health team where we were about 6 dentists in the sub-district coming to Knysna. I knew there was a task at hand. And so firstly, we had to create a vision. And our vision is to create a patient-centered healthcare model, which is reliable, sustainable, but most importantly, accessible for all. And it's pivotal because without vision, I read this proverb that says, without vision, the people will perish. And it's not as hectic as that, but I believe that if we don't have vision, we don't know where we are working towards. So on the agenda, we will speak about the initial challenge, our strategic response, 2 of the big projects that we did to change or have an impact in the communities, the key achievements and the lessons learned, and the future visions and recommendations that we had. So just to paint the picture, this is a map of Knysna and the Bitter sub-district. So it starts from the border of the Eastern Cape straight down to Sedgefield. The red dots indicate where our dental facilities are. So there's 1 dental chair in Knysna, 1 in Konakatula, and 1 in Plettenberg Bay. But as you can see, there's a large geographic area where 40%, we serve about 160,000 people, and 40% of them come from these rural areas. We have 13 primary healthcare clinics. So obviously we sat with a problem. We are a dental team of 1 permanent dentist, 1 seasonal dentist, 2 dental assistants, and 1 hygienist. So there was obviously a big disparity between the clinician to patient ratio. So like I said, the initial challenge was that we had a system under strain, a high burden of disease, widespread pain and sepsis among children specifically. There was extended waiting times where patients would have to wait for 6 months or more to get a treatment, because we work in the Western Cape on a booking system. And essentially people will come to the clinic and get there and they would say, look, your appointment is in 5 or 4 months' time. There was also obviously a lack of service points, and that created a significant barrier which affected rural patients more disproportionately. So these challenges created barriers to care, and it negatively impacted communities' health outcomes. So what did we do? Firstly, this is actually the first point we had to do. We had to set up more chairs. We had to expand our services. So unfortunately, because for 1 chair it cost the government around about 470,000 rand just for the chair to tender it, and then there's a lot of other things that have come to play. It wasn't feasible to do that. So what happened, one day I went into one of our condemned clinics that was here previously, that was utilized. I switched on the chair and I saw that it was moving mechanically. The light was working, but it was stationed and fixed to the ground. So I phoned the clinical engineering team and I asked them, look, we have these 2 chairs here. Can we utilize them? I want these chairs to be placed in clinics, satellite clinics, or one of the primary healthcare clinics, but it needs to be mobile, because these rooms, normally these clinics are very small, and these rooms are being used by a doctor or physio or a nurse. So I need these chairs to be mobile. So they came back to me and they said, Doc, we can put a platform underneath these chairs, engage the levers on these chairs and put it on wheels. That means the moment you get to those clinics, you can move the chair where you want it in that room, disengage the levers, the chair becomes mobile, not mobile, it becomes stationary there, you can utilize it, and then essentially treat it and create a dental practice feel in that room. So that's what happened. They gave me the 2 chairs, and we placed it in Sedgefield and Kieruk. And then I phoned him again. I kept on phoning him. I was like, I know you're building new clinics. Can I not utilize any of those chairs that you have in your warehouse? So they started giving me multiple chairs. And so essentially, that's how we expanded our services, our service points. We had added 5 additional clinics. We repurposed the dental chairs with support of the clinical engineering. And then obviously now we had to extend our times and extended our service hours. So I went to my managers and I asked them, is it possible for us to start doing evening clinics? Is it possible for us to start doing Saturday clinics at the provincial hospital? And then that's what we ended up doing. We also changed the booking system. We shifted it to a local clinic level. And so they only booked for 1 month in advance, and we saw full patient attendance at these clinics. So the key results was that we improved access for 40% of the patients in the rural areas. We increased our treatment capacity by 30% due to our extended hours. and we reduced our appointment waiting time from 6 months to essentially 2 to 3 weeks, because the bookings are only done a month in advance. And so this is how it looks like now. All the yellow spots are the new service points that we took essentially to the community, taking the service to the community. That is essential. And then what we had to do was we had to look at our kids. We had a problem with a lot of kids having to stay out of school. And due to being having pain and sepsis and yeah, it's just a lot of problems. And so I partnered with a private stakeholder, which is an NGO, Rotary Club of Knysna, and they funded this project. So it was a pilot project that we ran this year in Knysna, where I went to other sub-districts and I asked them for 1 week, will you be able to come and join us? We take hands, we do a high impact outreach within the Knysna area. We treat these schools, and then we bring it, we rotate it to every district therefore onwards. So that's just what happened. We served 5 schools. We treated 330 odd kids. We did over 898 procedures, upwards of the value of 750,000. And so I'll break that down just now. So we significantly reduced the backlog of urgent dental cases in the Greater Knysna area, and we've proven a sustainable, locally sourced clinician model for this outreach. And this initiative demonstrated that community-driven healthcare supported by strong partnerships can make a lasting difference. So just to break it down, in that 4 days, we did over 532 extractions, 127 fillings, and over 239 preventative treatments. This again was in 4 days with just a clinical team from Oosthuizen, which has 2 more dentists. So we were 4 in total, and 2 oral hygienists and 3 dental assistants. And yeah, the Rotary Dent Initiative successfully reduced the backlog of urgent dental cases in the Greater Knysna area, with a focus on addressing pain and sepsis with our extraction services, and the comprehensive approach that combined urgent care with preventative measures to cause sustainable oral health outcomes. And here's a couple of fixes. What we did was we set it up in a boardroom. We put all of that mobile chairs in one. We had a dental truck, mobile truck. We had 2 fixed chairs that can do fillings. We did dividers, and that's the team at the bottom that we had. We gave them preventative packs and oral hygiene packs afterwards with the oral hygienists. So yeah. Then I always say prevention is better than cure. We had to start looking at the problem, why our dental theatre lists are so long. That's when I went and partnered with the Knysna Education Trust. And we created a program, a preventative program. Our partnership was focused on establishing lifelong oral hygiene habits in pre-scholars, creating a foundation for long-term health. Because essentially, the Western Cape Department of Health had a preventative program, but it only starts from grade 1 or 6 years old, and this was focusing more on creche. So we supplied 1,778 toothbrushes, we had 828 toothpastes that we gave. We reached over 68 ECD facilities, and we trained over 293 teachers through 20 workshops, teaching them, giving them pamphlets, giving them posters that is culture appropriate in the communities that we all have. And we saw that we had fewer missed days from school, better self-esteem, strong school readiness, healthier smiles, fresher breath, and less plaque build-up. Yeah, and the spread program demonstrates how early intervention in education can significantly improve oral health outcomes and contribute to broader educational success. Just a couple of photos. There I trained and did a workshop with the principals. Then with the principals basically educated the teachers, and then we went to the schools, and the toothbrushing program was run out. So our oral hygienist then goes and monitors regularly. So I'm going to skip to the lessons learned and key achievements because I know my time is up, but I will go to the end and just in conclusion say that our strategic service redesign, our service innovation focused on accessibility and patient-centered care, and have created a foundation for impactful community health programs. Our private public partnerships with the Rotary and the Knysna Education Trust has reduced disease burden and improved oral health education. And we saw that we have a sustainable model, a proven sustainable model for future healthcare delivery that can be expanded. I'm happy to say that our chair's blueprint is being used in Oosthuizen, it's being used in Beaufort. Our Rotary Dent, like I said, is going to we've got the go-ahead to do it next year in Oosthuizen again. And so we are expanding it all across our sub-districts, and eventually it will be in the entire Eden and Central Karoo district where we are running this out. And so lastly, lasting impact. Our community-driven healthcare, supported by strong partnerships, can make a lasting difference in our health. Thank you for your time. I skipped quite a few slides, but it was just the key achievements and the lessons learned. Unfortunately, with the time, I couldn't go through those ones. Yeah, thank you, colleagues.
Thank you so much, Dillon. Please go into the chat. There's a lot of really great comments about this amazing initiative that you shared about. Really just showing us how even in highly pressured service areas like oral health, innovation is still possible. And you can really shift the entire patient experience. Yeah, through really just amazing initiatives from people who are very proactive like you in trying to make a difference. So I'd like to introduce our final speaker, who is someone who works at the intersection of innovation, systems, but also sustainability. We often say innovation is the easy part. It's making it stick, which is quite the challenge. So I'd like to welcome Almero, Dr. Almero Oosthuizen, who is the clinical lead for innovation and improvement in the Western Cape's CSI Directorate. And he will speak on what it takes to make innovation stick in the DHS. Over to you, Dr. Oosthuizen.
Thank you so much. And thank you for inviting me. Thanks for everyone who's here today. It's just genuinely such a pleasure to hear what we've heard so far and to spend some time with you. I often joke to say that I am tragically interested in making the world a better place and just about stupid enough to do that, to think that it's possible. And so whenever I'm able to spend time with other people that are also proud public servants that are interested in doing good things, it makes me happy. So let me share my screen with you guys and we can just run through this presentation. There we go. You should see it in presenter now.
We don't see the presentation. Yeah.
Okay, so you don't see it at all, or you just don't
No,
see it in presentation?
we do see it, but we're not seeing the presentation mode.
Give me one second so that I can just swap it around.
Yeah, swap your screens around.
Oh, how frustrating.
Sorry.
It's okay. How about now?
We're seeing presenter view.
And now?
Okay. Yes, perfect. Thank you.
Okay, wonderful. Okay, so so let's talk about making innovation stick. And Noluthando was right. So most of us operate in an operational paradigm, in a routine paradigm, which is where we have SOPs and procedures and stuff. We have business as usual. We know what works and we know how it works. And therefore, we have things like QA that can tell us when performance drops below a very high bar, because we should be performing near to 100%. But when you're doing adaptive work, so when you're doing innovation, you're trying to do something different, you're trying to do something new, the evidence, so now we're not talking about innovation culture, we're talking about evidence. The evidence is that in the best companies in the world, so Fortune 500 companies with the biggest R&D budget, the stick rate for innovation is about 8 to 9%. And in the best government innovation programs, the stick rate is about 3 to 5%. So the reality is that most innovations don't stick, and that's normal. So now, what do we do about that? So one thing that I just want to say is that it's very easy. Most of us are eager and impatient for progress. And it's very easy in that eagerness and impatience and frustration to put all our hope on one thing. Innovation is the magic one that's going to solve all our problems. But it isn't. Innovation is just one part of progress. It's just one part of making the world a better place. Good basic operations is another part. QA is another part. CQI is another part. Training is another part. And so while it's definitely a mistake to leave out innovation or doing different things from your progress strategy, it is equally as big of a mistake to put your whole hope for a progress strategy in innovation. Let's try and just sort of, I guess, frame our minds a little bit with a few quotes that I hold quite dear. And so, whenever I'm trying to do this work, when all of us are doing this work, it's tough. So we need to have something to hold on to. And so for me, I often ask, well, why do we even exist? Why does government even exist? And so I think that the purpose of government is to make it easier for people to live lives of dignity and meaning as they define it. So whether you're working in operations, whether you're working in early stage emergent innovation, whether you're trying to decide whether something should or could be replicated or scaled and pushing or retreating in that journey, this for me is the acid test. This is ultimately the way where in tough moments, it helps me to decide, is this thing going to make it easier for people to live lives of dignity and meaning as they define it or not? And if the answer is no, well, there are other things to do. And if we are in that journey, then this quote by Mugendi Mrita, who's an African design academic, follows me around. I think about it multiple times a week. He says, I participate, therefore I am. And so if we're interested in doing something different that is better and we're interested in making it stick, are we watching that happen? Or are we participating in that happening? I have the best job description in the world. I do good things with good people, as should all of us. And so that's another filter. Is it a good thing? Yes, no. Good people? Yes, no. We can't do everything. And then it takes what it takes. We often hear people say, no, it is what it is. We hate that. We think it takes what it takes. And if you don't do what it takes, then it is what it is. Innovation or doing something new or doing something different is not a zero effort and zero cost intervention, even when it is frugal. If you look at what Dillon did in the previous talk, that's a lot of time and effort and money, even though it's less than would have been that was spent. So it takes what it takes. And you often won't know what it takes. So as you walk on the way, it appears. And this last one is important. Your new life will cost you your old one. And so if all of us are in here and we're saying, we ask ourselves, are we satisfied with the way things are? Are we content? Do we think we're done? Have we reached where we want to be? Surely the answer would be no. Otherwise, we wouldn't be here interested in building the DHS and being responsive to the needs of people. And so therefore, we're not content. And so that implies that things are going to have to change. And you know what? We're also things. There's no way that anyone who is interested in any kind of progress in the world will achieve that without themselves being open to profound change. And I say that of us as people, but also of our bureaucratic processes. Okay, so now that we frame that a little bit, let's carry on. So if you're trying to make the world a better place, so whether you're trying to emerge innovation or whether you've emerged it, now you're wondering whether you should replicate, scale, or stick, that is a complex endeavor. Societies, people, systems that are complex. Linear games don't work. I'm here, that's our goal, this is how we're going to plan it, we're going to execute it like this, that's the deliverables, let's get it done. That works for operations. It does not work for innovation in socially adaptive circumstances. And certainty is not certain. It doesn't matter how passionately you believe something should or may be the right way to go, there are no guarantees. And what you think should be done, there are no guarantees. So we have to be comfortable with uncertainty. And we can't use goals as destinations because, again, the ground is shifting and our knowledge is developing. So goals are directions, not destinations. So if I say I want to reduce antibiotic resistance, as we said earlier, or I want to increase access to dental care, as we had earlier, then I can't put down some number and say, well, that's it all. No, there's a direction I move towards in the next phase. And conditions engineering outperforms outcomes engineering. Conditions engineering says what is necessary for the people delivering services to deliver the services that people deserve. Then you engineer those conditions and the outcomes will be achieved. But if you step over your mandate, our mandate to engineer performance enabling conditions, and we try and force an outcome into the world, it's going to fail. So if you're interested in emerging and sticking innovation, you have to understand that you are, as of now, a gardener. You're not a factory worker. The world isn't a machine. And you have to do what gardeners do, which is spend time there, tend the soil, pull out weeds, plant new things, prune, change, care, see what grows, reward what grows. In that, you might want to ask yourself, what is your role? So not everybody has the same role in this. So some people are the innovators. They're the people grinding, at the coalface. And some other people, and I suspect many people in this conversation are those people. Some other people are the stewards of the enabling environment. They're not doing the innovation, but they have to build the systems and the enabling elements that allow innovators to innovate. And as this scales, so does the complexity of the problem and the tools that you might want to use. For instance, if it's only me, I'm an entrepreneur, it's my money, I'm doing a single man business, it's easy. I just have to decide and move. But if I'm in a provincial department of health with 35,000 employees and 7 million customers and 5 political parties, it's a very different ballgame. So depending on the size of your innovation ecosystem and your position in it, you might need to deploy different kinds of approaches and strategies. And we'll touch on one or two of those now. But first, I need to dispel one or two very toxic and dangerous myths. First thing is, innovation champions are not a sustainability strategy. It's a toxic ideology. Champions find, emerge, and develop innovations, but owners take the baton and ensure sustainability. Champions have a day job. And so if an organization desires sustainability in something that emerged as an innovation, it has to invest exactly the same as they would in any other sustained program, which is it has to be someone's full-time job. There has to be management systems built around it. So the dependency, and often toxic dependency, on champions that are just soldiers that are being left behind to fight their own battles as a sustainability. So they can definitely be involved in emergence, but it's not a sustainability. There are many other common myths, things that I've had to learn the hard way. Just a few of them that I'll highlight here is many innovations cannot or should not be replicated or scaled. Some of them are only locally relevant. Some of them are workarounds to fundamental system errors. And it is not good to scale, replicate, and consolidate errors and workarounds. You should fix the systemic stack. So in that way, many of our innovations are like flares being shot up. So if you see a flare being shot up, an emergency flare at night in the park, you don't run to the flare, you run to where it was shot up from. So whenever you're encountering a cool new innovation, kick the ground a little bit and ask, why was this necessary? Is the right thing to do to take this plaster and make it part of the body? Or do we need to fix the wound? Knowledge hubs don't work. I put some in the chat about that. That's a different conversation. And innovation hubs or public sector innovation labs don't work. I've spoken internationally on that. Everyone who developed the initial models, Christian based on, none of them do it the way that most emerging governments are still trying to do it. So it's also, it's actually probably a net zero ROI. This is a difficult thing that anyone interested in change, and we all know this, we just often don't have language. So we think that if we have merit, i.e. I'm doing the right thing, and there's evidence, so I know that it works and how it works, then it should be adopted and the world will become a better place. It's a fairy tale, it's a fantasy. It just isn't true. There's a whole box of other things in between merited evidence and adoption and change. Policy alignment, program alignment, budget availability, capacity, timing, and then some bad things, incompetence, subcompetence, fraud, corruption. And so really your our effectiveness in hooking and sticking innovations and new things is more related to our successful navigation of other things than it is to the underlying merit evidence. I'm going to skip this for now, but you can think of other things along these two axes, but we can skip that for now. So as stewards in the system and innovators, we must make the other things box more transparent so that people on both sides of the divide know exactly what's in there. How do the processes work? Who do I need to talk to? What forms need to be filled in? What are the budget windows? And so on and so forth. So we must make it more transparent, but we also must make it easier to navigate. It's part of our responsibility to do that. So if part of our conditions engineering is making an easier to navigate, more knowable other things box, then we're way more likely to sustain innovation. The ingredient is not the stew. I'll skip this. This is maybe a fascinating thing to talk about on another day. But just to remember, if someone did 10 things to make something work, you can't take one part of that and think it's going to work. Now, if you want a second helping of stew and someone gives you a piece of raw lamb, it was in there, but it's not the stew. So things work together for a reason. The gate is something we can just touch on for 20 seconds. You have to cross the finish line before you start the race. Between other things and adoption is the gate. The gate is who or whatever makes a decision about whether something's going to be adopted. And if you don't ensure an open gate before you start the race, everything you do is likely to be waste. This is something that we can unpack as well. You have to get the gate open. You have to align before you design, before you invest a lot of time, energy. We'll skip this, but just as I mentioned earlier, routine and adaptive work is not the same thing. It's not about the one or the other. It's about, do you have both, and are they connected to each other in tension? So a few little summary points is innovation is just part of progress. It takes what it takes. You can't negotiate with that. The single best thing that you can do is to start building enabling environments at a systemic point of view and forget about innovation culture. We already have enough of complexity rules. You have to become an other things box expert. You have to remember to cross the finishing line before you start and align before you design so that you designed it. Thank you very much.
Thank you so much, Almero, for just sharing such critical insights on institutionalizing innovation. Yeah, there were so many interesting things that I picked up in your discussion, but I think one of the key things about having an enabling environment, highlighting the importance of what is our role in the innovation, what is our role in ensuring that we are all improving the system. Otherwise you just, you're just idly watching somebody else carry all the weight. So really appreciate it. Before I hand over to Lucy, I'd like to see if we can just get any other audience engagements. So, question for you, Almero, before you disappear. Do you have any suggestions on how to secure that upfront investment in innovation with sometimes uncertain outcomes and avoiding the low-hanging fruit trap? Great question from Leandri. Thank you so much.
Yes. So again, the key is, so you don't want to throw the ball and then start looking for someone to catch it. You want to play catch. So someone must be ready for the ball before you throw it. And there are a few different ways. The first one, and this is also highly evidence-based, is you need to be aligned with the strategy and activities of the organization in which you are innovating. If your organization is prioritizing and is strategically committed to, for instance, child nutrition, the likelihood that you're going to be able to successfully push and hook cosmetic surgery, no matter how much you think you should, is very unlikely. So alignment in the broader tribe is important. So that's a generic strategy. But a specific, a second one is be really good at what you do. So just be good at what you do, because you'll build the capital that you need to have a little bit of leeway. And then the last one is you have to figure out who and what the gates are along your way. And you have to invest consistently over time in engagement and relationship, merit-based, not bypassing, merit-based with those gates, so that you can engage with them at the early stages of development of an idea.
No, that's great insight, particularly in the public health sector, where there are a couple of gates. So thank you for that. Last question from Lucky. Lucky says thank you, and has a question for you again, Almero. How can district level leadership support facilities in moving forward on the quality health service delivery?
You know, if I wish I had the full answer to that question, and also the one on which I'm speaking, because I would be a very rich person if I had the full answer. But so instead of trying to give you a cookie cutter thing, I'm going to tell you, I think that you have to hold two things in constructive tension with each other, and that is humility and courage. If you're interested in making the world a better place, then you need to be humble, because it's only when you're humble that you can hear and see the world for what it truly is, not for what you hoped or wished or wanted it to be. So if you've been humble enough to listen, to go to these facilities and places and teams to understand what it is that they need, then you need the second thing, so humility, then you need courage. Because without courage, you're not going to act on the truth that you found, regardless of how uncomfortable. And so humility will show you the way, and courage will take you on the way. And I think regardless of the complexity in the details or anything else, if you've got a heart for service and you're willing to put sweat of your brow into the betterment of the lives of people, and you go to places with humility and you respond with courage, you've gone a long way towards being able to deliver the type of support that people deserve.
Thank you so much. Great way to close off our audience engagement. Just thank you for the rich comments and the reflections. And these conversations are exactly why this platform exists, why these webinars exist. So we can talk honestly about the system challenges, but also the opportunities that exist, so that we're not always focusing on what is wrong and always diagnosing and not looking at ways in which we can improve things. So to close us off, I'd now like to hand over to Professor Lucy Gilson, who will reflect on the key themes that have emerged today, but also share what's ahead for SALET as we move into 2026. Over to you.
Thank you so much, Noluthando. Thanks very much indeed. Well, what another fantastic afternoon, colleagues, with examples of good practice, of innovation, but actually of passion and commitment in our district health system. Thank you to Malcolm, thank you to Dillon for sharing your experiences of making a difference in the world in which you exist. Differences based on relationships, differences based on boundary spanning, making a difference by your own characteristic of engagement and commitment. So your innovations, I'm going to call them both innovations, just so important and so indicative of the people that you need to be, but of the teams you need to work with. And I think we all commented on how wonderful it was to hear the experience of CHWs, environmental health practitioners, oral health practitioners, colleagues whom we perhaps don't hear enough from in our everyday life. And along the way, we actually heard some other experiences, both, in fact, from the Eastern Cape. Bulela introduced the Eastern Cape innovation or best practice that he'd hoped would have been in the HST repository, but never quite made it. Again, an oral health example, fantastic. And Dillon spoke about having been in the Eastern Cape, where there was a bigger oral health team than he found in Knysna-Bitu in the Western Cape. So we also heard a little bit about Eastern Cape experiences along the way, which is fun, which is great to hear. I think that the examples were then nested in to wider perspectives. On the one hand, the HST repository, which many people acknowledged is going to be a great resource for us all. And it's good to know that the range of best practices will be quite diverse. I've put in the chat box the types of innovations that registrants noted when they joined us for this session, best practices or good practices and innovations, and they're very wide-ranging: governance and ethics and quality, clinical practice, COPC, digital health and data systems, workforce and capacity development. There's lots of good practice out there. It's important that it is gathered, but more importantly, that it is shared. And I noted in the chat box that there was a lot of interest in the idea of the repository being more than a repository, being, for example, a connector hub. And I'm sure that HST is thinking about how to do more than simply gather the knowledge, but also share and engage others with it. And then let's come to Almero's input and, some might say philosophical, but totally rooted in real experience of seeking to implement innovation, but are seeking to create the environments that enable innovation. And I think, Almero, in your presentation, that focus on we need innovators, but we shouldn't leave it to the innovators only. We need to create conditions for innovation. We need to be, all of us, stewards for enabling innovation. And we need to think about when to scale up and when not to scale up. And we need to think about how to create the environment that others are constantly innovating and developing and contributing to strengthening the district health system. And across all of our speakers today, just to come back to that sense of passion and purpose and commitment, public sector value being at the heart of what you all do, and that it's been inspiring to hear about. So that's a very brief reflection on what we've heard today. From the SALAD webinar group, I want to also just reflect on what we've done this year before I move on to next year. And just a reminder, this is the 6th of the SALAD webinars this year. We've addressed the the US foreign aid freeze way back in January. We've thought about leadership and leadership development. We've thought about reorienting the district health system to health promotion and wellness. We've looked at how we move beyond compliance in quality to make sure that norms and standards support quality improvement and are not just compliance focused. And today we've spoken about innovation and best and good practices. I think across all 6 webinars, we've had wonderful examples of good practice from the district health system across our country, from many different provinces. And it's been fantastic to hear from the work in districts and to be able to create a platform, as Noluthando has said, to share experience. And as we think about how to create the enabling environment for innovation in the future, SALAD puts its hand up to be part of that sharing space, that learning space. And we are wonderfully engaged with HST. It's been great to have more of HST here today. Noluthando, thank you so much. We're wonderfully engaged with our provincial colleagues from all 9 provinces. And thank you to them for the engagement we've had with them. SALAD as a space is a learning network and it's a learning hub. And perhaps we can in future call ourselves a connector hub as well. So as we look forward to next year, we do not yet have webinars planned, but they will be out there. So please look out for the webinar announcements. Please continue to join us. If you have any webinar ideas that you'd like to put forward, put them in the chat box now. We listen and we are listening. So please, for next year, if you have topics that you want us to create a space to share experience around, put them in the chat box or share with us separately. I'd like to thank today's speakers, Mashudu, Malcolm, Dillon, Almero, for their wonderful insights. I'd like to thank Noluthando for fantastic facilitation. And Noluthando is part of the webinar design team for SALAD with Caressa. Thank you so much, Caressa, for all your work in the year. Sipokule, thank you for your support to the webinars this year. Suklili, Leila Najjar, Eleanor Ali, And Chris, you had to leave early. Jenny Nash, thank you to all of you for supporting the webinar engagement. Colleagues, it is coming to the end of the year. It's been a long and, as ever, demanding year. But what a wonderful way to end with examples of passion, commitment, making a difference in the district health system, the foundation and the front line of our system, public and private. And we so appreciate you being with us today, and we very much look forward to being with you next year. We will, as ever, develop a note from this webinar, share that note with all participants and registrants, and please do, as I said, look out for webinars next year, look out for other SALAD activities. By joining the webinar, you become part of the SALAD family. So to everybody involved today, thank you so much. Siyabonga kakhulu, kakhulu. And may the end of the year be a very good one for you all. Thank you so much, Noluthando.
Thank you also to you, Professor Gilson, for being part of our team and always holding us together. Truly appreciate it for all your insights. And thank you to everybody for joining today. We really appreciate it. Such great insights, our presenters, and for all the engagement. Thank you. And yeah, enjoy the rest of the year. Goodbye.
Bye-bye. Keep well.